Yeah, ma'am. Once you have opened the Zoom, you
Hey,
have to.
I'm not able to see. Are you able to see me?
Yeah, yeah, I am able to see you, ma'am. You have to press on Zoom in the below. You see
Okay,
below
okay.
that line is
No,
called
no,
the
I have done
taskbar.
that. Okay.
Yes, 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 ma'am.
Yeah,
So now you see the share button in the middle, green
yeah,
color.
yeah,
Yeah, press on share, and then now you will see some application windows
yeah,
where
yeah,
your PPT would be visible there.
yeah,
Please
yeah.
select the PPT and now then you press on share.
अभी
You
कर दे शेयर? नो.
हाँ हाँ आप अभी कर सकते हैं मैम चेक करने के लिए. Yes. Yes, now your screen is coming, ma'am. Yeah, now I can see. So you press on enable editing first. You see that
Where?
enable editing. Yeah,
This.
yeah, this that one, ma'am. Just
This.
above that, you see enable editing protected view जो लिखा है.
Mm, yes, yes.
Yes, ma'am. Enable editing पे click करिए. Yes, ma'am. And now, once this comes, yes, ma'am. Now it has come. Now you see there is slideshow written.
Yeah, yeah, yeah. This one, no?
Yeah, yeah, exactly, ma'am. Slideshow is there. You
Should
have to
I
press.
start
Yeah, you have to
straight
press on that first, and then you see the on the left side there is
from
beginning from
beginning?
beginning written. Yes, you have to press on that. Yes.
Is it
Yes,
okay?
ma'am. Now it has come. Yes, ma'am. Perfectly. So now what you can do? Yes, it is moving also. So you can come to the first slide on the left side. Yes. Now you just stop the screen sharing, ma'am. You see, just stop share would be visible.
Yeah, yeah.
Yeah, just press on stop share. Fine, ma'am. This
Okay.
is done. Okay. So now we have 15 minutes to
Yeah, yeah.
yeah, 12
तो
minutes are
जब
there. Yeah.
स्टार्ट करना होगा देन अगेन ग्रीन बटन दबाना है.
Yeah, again वहीं से same way में ma'am, same procedure. Okay, and I'll just take 12 minutes are there, ma'am. So I'll
Yeah.
just take 5 to 10 minutes to check some technicalities and I'll be back, ma'am. Okay.
Okay, okay, okay.
Yeah, ma'am.
Okay.
Thank you.
Uh, I should keep it open now.
Yeah, you can, ma'am. You can, or you can just mute yourself, no problem. उसके बाद
Oh,
फिर हम लोग start करते हैं. 5 minutes मुझे दीजिएगा.
nothing like that. But in case of emergency, I can't say, but otherwise it is a stable connection, no problem.
Okay, ma'am. I hope everything is perfect and your background is also clear and perfect. I see. I'll just request you to remain in this stable position. And I see that you have also put the blurred background also, and everything is perfect, ma'am. Thank you very much. So we'll start with the introduction. So we still have 2 minutes to go
Okay, okay.
live. So I'll just keep everything ready. Okay. And once I complete the speech, then only you can start sharing. Okay.
Okay.
Yeah, ma'am. Fine.
Just wait.
Yeah, okay. No problem, ma'am. Yes, ma'am. We have 1 minute to go. Then we'll go
Okay.
live. Okay.
Audio is clear?
Yeah, perfect, ma'am. Everything is perfect.
Okay.
Okay, ma'am. So, with all your permission, we are going live. It's almost time.
Okay.
Greetings and a warm welcome, everyone. I am Asya, the assigned moderator from Clarinet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Clarinet, to you all. It proudly stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Sumati Saxena ma'am, who is a highly experienced senior consultant in obstetrics and gynecology with over 30 years of clinical expertise. She holds an MBBS, MS in obstetrics and gynecology, and is an FMF certified first trimester screening operator. Dr. Saxena currently practices at her own clinic, where she continues to provide compassionate and expert care to women across all stages of life. The topic of today's session is early ultrasound markers to predict adverse outcomes in the first trimester. I would like to give you an overview of today's topic before we start the session. Early ultrasound markers in the first trimester are valuable tools for predicting adverse pregnancy outcomes. Measurements such as nuchal translucency, thickness, crown rump length, and the presence of or absence of the nasal bone can provide early indications of chromosomal abnormalities and structural anomalies. Abnormal findings in the yolk sac, gestational sac shape, or embryonic heart rate may also suggest a higher risk of miscarriage or developmental issues. The use of these markers allows for timely counseling, further diagnostic testing, and early intervention. Accurate assessment during this period enhances the ability to manage pregnancies with increased risk more effectively. So, without any further delay, I would like to hand over this session to Dr. Sumati Saxena, ma'am. Please proceed with your talk, ma'am. Over to you.
Thank you. Thank you very much for your kind words and giving me this opportunity to share my views on this topic. I I will like to share my presentation. So the topic, good evening, dear friends. The topic for today's webinar is excuse me, ये ऊपर आ रहा है इसको. Thank you. Topic is early ultrasound marker predicting adverse outcome in first trimester of pregnancy. And I am Dr. Sumati Saxena, practicing in Lokhandwala, Mumbai. So this slide is not moving. Okay. So my presentation will go through all these points like introduction, what are the key ultrasound markers, and what are the specific markers predicting adverse outcome and their clinical implementation. So, as all of us know that ultrasound plays a vital role in early detection of pregnancy anomaly complication, and if we are aware of these complication early in the course of pregnancy, we can timely intervene and do the proper management, and so there is decreased risk of mortality and morbidity in the pregnancy. So ultrasound is a big boon for every obstetrician, and it is a non-invasive technique, so all obstetricians should be very thorough in the ultrasound knowledge, because even if they are not doing their own ultrasound, they are not doing ultrasound of their own patients, but they get report from the radiologist. If they have good knowledge of ultrasound, they can comprehend the report and they apply the report in their clinical management and get good outcome. So there are certain markers. When a lady comes with a history of amenorrhea, her urine pregnancy test is positive, her beta HCG is around 1500 units. That then, when you do ultrasound, there is appearance of anechoic circular structure in the endometrial cavity placed eccentrically, and that is gestational sac. And when you do see the gestational sac in the uterine cavity, then you have to note down certain points about it, that what is the number, where it is located, what is the shape, what is the size, and what is its content. Very important. So when you see the number, when it is single gestational sac, it is singleton pregnancy. But when there is two or more gestational sac, then it is multiple pregnancy. And multiple pregnancy is categorized as a high risk pregnancies. Then you take proper care from this early in the pregnancy. You can diagnose the case and take the proper care. So then you, if you see that the gestational sac is located low lying, located in the lower segment of the uterus, then there are two possibility. Either the normal pregnancy is implanted in the lower segment of uterus, or the normal pregnancy is implanted in upper segment, is aborting and passing through the lower segment. Then even a gestational sac is seen in the lower segment. So then you can differentiate in between the two by applying the color Doppler in the ultrasound. If color is present, then it is a normal pregnancy which is implanted in the lower segment. If color flow is absent, then it is the aborting pregnancy which is passing through the lower segment. So this is very important. And also when the pregnancy is low lying gestational sac, you have to differentiate it from the cervical pregnancy, which is a form of ectopic pregnancy and very life threatening condition. And also you also look for any history of previous cesarean section in case of low lying gestational sac, because if it is previous cesarean section, then it can be cesarean scar ectopic pregnancy, and there are chances of morbid addition of placenta. So all these things are taken into consideration while seeing the gestational sac in the uterine cavity. And also you should take under consideration the shape of the gestational sac, whether it is irregular, it is regular circular, or it is irregular. If gestational sac is irregular, it is suggestive of poor outcome in pregnancy. But no single finding is conclusive. You have to take under consideration other factors also. And when the size of gestational sac is small, corresponding to that gestational age, and the fetal pole is filling the gestational age sac, there is no fluid like the difference between the mean sac diameter and the CRL is less than 5 millimeter. It is also a feature which suggests poor pregnancy outcome. Then the content of the gestational sac, you can see that if the gestational sac is empty, the on transvaginal ultrasound or transabdominal ultrasound, when the mean sac diameter is more than 25 millimeter, then it is suggestive of an embryonic pregnancy or missed abortion and a form of pregnancy failure. So, in early diagnosis, even with a single feature like gestational sac, we can predict many things. The next thing, when the pregnancy is around 5.5 weeks and all, then the circular anechoic structure appears in the gestational sac, and that is yolk sac. And the yolk sac is the structure which provide nutrition to the pregnancy. So it is very important. So when you see the yolk sac, you should see whether it is thin walled, thick walled, circular, and diameter is more than 6 millimeter. It is normally 2 to 6 millimeter in diameter. If it's more than 6 millimeter, it is suggestive, predict points towards the poor outcome. And also whether it is calcified. So all these features are suggestive of poor pregnancy outcome. So you should become alert and do the proper management. And also number of yolk sac is also very important. If you see two yolk sac, then it suggest of multiple pregnancy, and each yolk sac depicts one amnion. So if two yolk sacs are seen, then it is diamniotic pregnancy. So it is a very important feature and marker for the pregnancy well-being. Then, when you see around 6 weeks in the gestational sac, after the development of yolk sac, there is appearance of fetal pole. That is, fetal pole is appears in 6 weeks of pregnancy, and when it appears, then we measure the crown rump length, CRL, and the crown rump length is the longest length of the embryo, excluding limb and yolk sac. So if it is CRL is less than expected CRL according to the gestational age, it may suggest potential fetal growth restriction, indicating the need for close monitoring and additional assessment. So it is a very important feature. And when a fetal pole appears in the gestational sac, we also look for the cardiac activity in the fetal pole. If cardiac activity is absent, then it is a missed abortion and it is a form of pregnancy failure. But if cardiac activity is present, then we note its heart rate and the rhythm. And the heart rate is normal 120 to 160. But at around 7 weeks, if the heart rate is less than 100, then it is known as fetal bradycardia, and it is also suggestive of poor pregnancy outcome. And it is, if there is any irregularity in the fetal heart rate pattern, it is also an indicator of cardiac defect warranting comprehensive echocardiography if needed. Also, when you are doing 11 to 13 weeks plus 6 days scan, that is NT scan, and you find out that there is uh, some type of trisomy because of some features, then because of by adding the cardiac activity, you can differentiate between the different types of trisomy. That if in trisomy 13, in trisomy 21, and in Turner syndrome, there is fetal tachycardia. In cases of trisomy 18 and triploidy, there is fetal bradycardia. So you can differentiate between the trisomies if in the case of first trimester screening also. So nuchal translucency. What is nuchal translucency? Nuchal translucency is collection of fluid behind the neck of the fetus. And on ultrasound, it is seen as translucent area behind the nape of the neck. And if it is more than 95 percentile for that gestational age, then it is increased nuchal translucency. And it is associated with chromosomal abnormalities, such like Down syndrome, or it may be because of congenital anomalies, and or because of some syndromes also. So you have to become careful when you see increased nuchal translucency, and you can then opt for invasive testing if you want to. And there are some specific markers which predict adverse outcome, like subchorionic hemorrhage. When subchorionic hemorrhage is seen, it is may be associated with increased risk of miscarriage. So it influences patient management. So in more frequent follow-up visits are required. Bed rest is advised. Progesterone is advised. So if you detect subchorionic hemorrhage early in the course of disease, you can take you can preserve the pregnancy. Also, in ectopic pregnancy, which all of us know is a life-threatening condition, we can diagnose it early in the first trimester with the help of ultrasound. In the ultrasound, if you see no gestational sac in the uterus, but in adnexal region, you see a circular structure, and which is known as tubal ring. It is suggestive of ectopic pregnancy. And also, if you see any gestational sac with fetus or without fetus in the adnexal region, then it is also diagnostic of ectopic pregnancy. And if ectopic pregnancy is diagnosed early, you can save the life of patient, and you can save the complications, and decrease the morbidity and mortality. So also because of the nuchal translucency, you can see that there is a fluid collection behind the nape of the neck of the fetus. And if it is more than the 95 percentile for that gestational age, along with other features like nasal bone, tricuspid regurgitation, appearance of a wave in the ductus venosus, or shortening of limb, then you can suspect chromosomal abnormalities, and you can go for invasive testing. Also, because of the invention of a high resolution probe, very good quality of ultrasound machine, first trimester provides a very good opportunity to look for early congenital anomalies. So you can see that we can diagnose various type of anomalies by using ultrasound. So if they are detected early in the life, there is less of physical and mental trauma to the patient. So we can do the diagnose many congenital anomalies. Excuse me. Also, if you apply color Doppler to uterine artery in the first trimester, then by measuring the PI of uterine artery, you can predict preeclampsia, development of preeclampsia later in the pregnancy. So you can predict very early in the pregnancy by applying the color Doppler to uterine artery. And if there is prediction of development of preeclampsia later in the life, you can very well advise lifestyle changes to the patient and also medication like aspirin so that the preeclampsia can be prevented and also complications are reduced. So it is very important tool for predicting preeclampsia. So, in conclusion, first trimester ultrasound offers valuable early insights. Several markers can flag higher risk for adverse outcome, and early identification leads to timely monitoring and interventions. Thank you very much. Hello, Asya. Are you there? My presentation has ended, Asya. Hello. Hello, Asya. And is anyone there? Hello, Asya.
Hello, ma'am. Am I audible?
Hello.
Yes, ma'am. Am I audible?
Yes, yes.
Thank you very much, ma'am, for your wonderful talk. The presentation was really informative as well as lucid. And so sorry for the technical glitch, ma'am, because of some problem. I was not able to hear you
Okay.
at the last. Yes, ma'am.
So there was no participant. Is it recorded or something like this?
No, ma'am. It is in here. There is not no participants, ma'am. The participants come live. So thank you very much for the wonderful talk.